we're going to get started, and we're just going to do some immediate kind of introductions. So hopefully if a few other people join us, they won't be behind. So welcome everyone. My name is Kathy Gorash, and welcome to APHA ATOD's Integrated Behavioral Health Spotlight. It's the first one we're doing this year. My name is Kathy Gorash, and I've been a longtime member of APHA, active in several sections, past action board chair, executive board, and all of that good stuff. But I've been pretty much focused on ATOD since 2007. And we formed the IBH work group, of which we're well represented on this call today, to address the growing interconnectedness of behavioral health, which is SUD and mental health, as with primary care and for those in care. We have people in ATOD section who are used to just working in their silos, and so we're trying to do a through line across all of our ATOD section, and now other drugs is opioids, cannabis, and the list kind of goes on. It would be great if you, while I'm finishing up and getting ready to introduce our facilitator in the program, if you could indicate in the chat, as it says on the left-hand side of the slide, how you heard about this spotlight. We want it for future spotlights to know what is the right mix of communication. Although you might have heard from multiple things we've done to promote it. But so you know, the IBH work group, for those who are not already in it, really started in 2023, and we were trying to develop a working definition of what integrated behavioral health was. And we did a word cloud of our leadership and a word cloud of, you know, the leaders in the country, like SAMHSA, CDC, what their definitions were, and nothing was the same, and the word clouds couldn't have been more different from each other. So we spent time last year trying to flush it out to come to something that we could work with in the capacity we were all working in within APHA and the other work that everyone does. We had 2 oral sessions, 2 poster sessions. But in 2024, we added, once we kind of got that nailed down, more or less, it's evolving, the definition, we added providing spotlights to share the knowledge, to shine a light on this growing and needed area that is just now, we were talking before this started, just now getting some traction. But it's slow, and we'd like to, you know, keep it moving. So thank you. We had in 2023 a planning group, some of us here, including, Dr. Gettinger, Josh Gettinger, who really helped spearhead this session we have today. We've worked with HRSA, getting input, and that's kind of what took us to today. You'll see up here the working group definition that we have on the right-hand side. Very long, very cumbersome. Used it in the abstract, call for abstract, to try and touch people in some way for when they were submitting their abstracts. And of course, still, we got abstracts that had nothing to do with integrated anything. But that's how it goes. We had less this year than last year. So with that, I want to get us started with our topic today, which you saw on the first slide. Where did it go? Utilizing IBH to increase access to opioid use disorder and care. We have 2 presenters who will be introduced in a moment, and this will be facilitated by Dr. Manderscheid, who has a long, extensive history, which you could read here, but all things behavioral health. Any way you slice and dice it, that's him. And also as a past chair of the APHA mental health section, I think he brings great knowledge, and so appreciate you in this role with us today, Ron. So I'm going to turn it over to you and let you get started with our speakers.
Yeah. Thank you very much, and thank you for inviting me today to participate with you. I think integrated care is one of the most important things we're working on right now. And what I want to do in beginning here, before I introduce our two speakers, is take you through a minute or so of the history of integrated care in the United States. So the original work in integrated care in the United States began in the mid-1970s, and it did not begin in behavioral health. It began in federally qualified health center programs in New Haven, Connecticut, and New York City. Very interestingly, they were way ahead of the time. They saw the possibilities here, and they actually began doing this. So there's a very long history of doing integrated care services in the federally qualified health centers and the rural health centers. We move on up to the 1980s. At that time, both NIMH and NIDA were doing research on people with various behavioral health conditions. I was involved in some of the research in NIMH, and our research in NIMH showed that people who have a primary mental health condition are likely to get chronic diseases earlier and more severely than other people, all other things being equal. That was kind of a radical finding back in those days. But it had, I think, an effect in stimulating more work to be thinking, well, what are we going to do about this? How are we going to begin integrating and so on? Jump ahead to 2000, the U.S. Surgeon General Satcher, took on integrated care as his agenda for the future. He said the next decade of work in behavioral health is about integrated care. Move on to the ACA in 2010, integrated care. The Affordable Care Act was a major part of the Affordable Care Act. And the Affordable Care Act actually laid out various pathways to implement and develop integrated care. And actually, if I look back at that whole history, I would say we actually really started in a more broad way implementing after about 2015, and particularly after COVID began. And what greatly facilitated that work at that time was the fact that this was being done in a virtual way. So that's a 1-minute history of integrated care. For myself, I'm currently working on a paper on integrated care. And what I'm doing in that paper is I'm going through the history that I just kind of recited for you. I'm looking at what the current situation is, but I'm also then looking to the future and say, what are some of the next steps we need to be taking in order to move integrated care? And I'll be very happy to share that paper with you once that paper comes out. I'm in the process now with working with the reviewers on the paper and responding to their comments and so on. So with that brief introduction, let me go on and say just a few words about our speakers. We're delighted to have two speakers from MAHEC in Asheville, North Carolina. MAHEC is an area health education center and does very interesting work in this particular space that we're talking about today. And our two speakers that we have from MAHEC are Dr. Blake Fagan, who is a faculty physician and clinical director of the substance use program, and Zach White, who is the program manager for the Office of Opioid Treatment, both in the Department of Family Medicine. So we're delighted to have both of them join us. So I believe I'm going to turn it over to Zach, who is going to begin here. So Zach, the floor is yours.
Great, thanks, Ron. Can everybody hear me okay?
Yep, you're good.
Great, thank you. Thanks for having us. Let me just load my slides here. So yeah, thanks for having us to talk about integrated behavioral health and how we can utilize that to increase access to care for substance use disorders. And in our case, we're primarily focusing on opioid use disorders. So click, okay, there we go. There's our credits. And here's our outline. We're gonna try to leave 15 minutes at the end for Q&A, which tends to be my favorite part. And yeah, I'd like to just kind of set the stage by talking a little bit about what a substance use disorder is for anyone who might need to hear that. There's a lot of different ways to define a substance use disorder. We see the APA definition there. We can think about it in more biological terms, as far as a disease of the brain that changes the way that we think and behave and show up in the world. We can think of it as again a chronic disease with effective treatments. My personal go-to definition isn't on here, which is ritualized compulsive comfort seeking. And I like that definition in part because I feel it humanizes the person who is experiencing the substance use disorder, because seeking comfort is something that we can all relate to, and the people who we are trying to serve are no different. So there we go. That button works better apparently. So again, in a medical model, we often think of this substance use disorders as a chronic disease, and one reason we do that is because it feels familiar in a medical setting, right? I can speak and communicate with medical providers about substance use disorders and equate it to things like hypertension and things like asthma. Heart disease conditions that medical providers are well versed and comfortable and know how to treat. We have the system set up to treat chronic conditions, and really we have found at MAHEC that once we plug substance use disorders into those systems, it works great. We're able to save lives. We're able to improve health. And keep people engaged in care. I don't know if you've heard, but stigma and bias is a problem when it comes to substance use disorders. We see here 4 of the factors that really contribute to stigma and bias when it comes to substance use disorders. So seeing it as a willful choice and not as a disease. So by the time folks show up to a medical office to seek help for this, if it ever was a choice to initiate their substance use, it typically, in my experience, has long since stopped being a choice and is now a pattern of behavior that they feel they must engage in, and it can really, in the case of certain substances, can be dangerous to stop without assistance. So seeing it as a willful choice, also separating substance use from primary care. I used to, when I first started in this role, one of my jobs was to answer the phone and help folks get into care with us as quickly as possible. And one of the questions I would ask everyone is, do you have a primary care provider? And I would say that the most common answer that I got to that question was no, but I've been wanting one. I've been needing a doctor. I've got all these conditions, not just my substance use, but all these other medical conditions that I really need help with. And I would love to have a doctor. So integrated behavioral health and integrating substance use care into a primary care setting gives us a wonderful opportunity to provide that care in kind of a one-stop shop setting. Language is, and the types of language that we have become accustomed to using when it comes to substance use disorders can have the effect of stigmatizing patients and keeping them out of care, perpetuating the shame that goes along with substance use and the disorders that can develop along with that. And then importantly, a lot of our work recently at MAHEC has focused on helping folks coming out of carceral settings, prison and jail, to getting into care. And we know that those folks are at extremely high risk for overdose. And yet historically the justice system hasn't recognized medical care for OUD as a necessity for for those who have been incarcerated. Thankfully, I do see that changing. And I do see resources being devoted to that, which is really necessary to again stop the high rates of overdose that those folks experience. How do we address stigma and bias in healthcare? We start by establishing relationships, and I'm really grateful to not just our integrated folks, but our medical providers at MAHEC as well. I think they do a great job of getting to know their patients and establishing a relationship, showing up in the room, in the exam rooms in a way that's curious and non-judgmental. You hear Blake say that over and over again, and I think it's because we can't say it enough. That is kind of the starting point for doing this work, is being curious and non-judgmental. And along with that, practicing in a trauma-informed way, which we'll talk about in some more depth here in a moment. We want to empower patients. Our patients who've developed SUD and OUD are historically marginalized and disempowered, if only by the use disorder itself. Maintaining your health while you're experiencing a use disorder can become a full-time job. Simply waking up each day and trying to find the next pill or the next substance that is going to keep me from getting sick is a lot of work and really dominates the lives of the people who we serve. So we've seen through prescribing medications for OUD how that can really free up the lives of the folks who we're serving. And we want to empower them through two-way communication and making this feel like we're partners in their care, and not paternalistic. And then it's not enough for just the medical providers or even just the behavioral health folks to engage with folks in an effective way. But we really have found the need for all of our staff, whether it's schedulers, triage nurses, front desk staff who are checking folks in, really need some level of education around why we do this work, how to interact with folks with substance use disorders, how to do that in a curious and non-judgmental way. And then help those staff to feel empowered to reach out to someone like me if they do need more help. All right, with that, I'm gonna hand it over to Dr. Fagan, who's gonna talk about
Next slide.
what looks like.
Yeah, so just real quick then, MAHEC, we're in Western North Carolina. We started back in 1974, and we built a lot of residency programs, including our family medicine residency program. Now we have a psych residency program as well, and we're seeing over 250,000 patient visits. Next slide. And this is kind of how our office-based opioid treatment started. And the theme is, as we got started, we realized that we needed integrated behavioral health to treat our patients with opiate use disorder well. So back in 2013, we realized that we had people in our clinic that had substance use disorders, but particularly opiate use disorders, but we really weren't treating them. We weren't actually using the medicine buprenorphine. We weren't screening well. So we got set up and we started writing buprenorphine in 2015. And then you can kind of see as we got going more and more in 2017, we realized when we got to over 100 patients that, oh my goodness, we need to hire an LCSW LCSW that's a licensed clinical addiction specialist to join our team, which had a nurse practitioner, a doc, a pharmacist, and then Zach joined our team. And with having integrated behavioral health, having Zach in the clinic with us when we saw the patients really helped us immensely. And then next slide, fast forward, we've now, in last year, we saw 940 individual or unique patients. That was several thousand visits, but we also have peer support now. So the bottom line is, when I'm seeing a new patient, I come in the room and I'm like, I'm glad you're here. I'm glad you're alive. We're going to get you what you need today with, be it buprenorphine or what you need. And then the peer support is right there. Behavioral health comes in to have a touch with them. And it really is an integrated model that our patients like. Next slide. So this is really the team. And you might say, like, why do you need all those folks? But on the prescriber side, we have the family medicine residents, and the faculty, and the APPs. We have nurses that help to coordinate and to give some of the medicines, like the longer acting injectable medicines, like the injectable buprenorphine, and pharmacists that help us to write our protocols, keep us in line, and tell us about the new meds and the new things, unfortunately, that they're cutting into the drug supply, into the fentanyl supply, and really keep us up to date. And then the key is that peer support and behavioral health that's in the room. Next slide. So here's a picture of the crew. There's Zach on the right. But when a patient, particularly let's just say a new patient comes in that has a fentanyl use disorder, they are often calling the certified addiction RN, that's Maddie there, and they're getting their appointment right away. We try to be as low barrier as possible. When they come into clinic, they're boarded and put back by Lee, that RN, and then they get to see Carrie Dell, and she introduces them to Zach and our peer support, which is Chris Barney there, the CPSS. It's awesome. Next slide. And this is what we hear as feedback from our patients. What they really like about it is that their care for their medical conditions and their care for their substance use are not siloed. We also take care of their behavioral health. So they like coming into the waiting room. They get called back just like anybody else. No one knows why they're there. Maybe they're there for their high blood pressure, but maybe they're there to talk about their fentanyl use disorder and get some buprenorphine or Suboxone. We've taught our front desk, our phone system, and our lab to not be judgmental, and they take care of them like they take care of all of our other patients. And then when they get in the room, they actually get all the services they need in the room. So it's oftentimes that I come in the room and the peer has already been talking to them, found out that they're having housing instability, and they're already in the room helping them to sign up for housing, or maybe to get them a bus pass so that they can make their appointments on time next time. I come in and talk to them, and when I'm done, if they're seeing Zach or one of our other behavioral health, they'll stay in the room, and then that person comes in and starts doing the counseling with them. Next slide. And this is kind of the process. As you're reading there, I'll kind of just go over it. But when we get a phone call, we have a customer care associate, someone that answers the phone, or our RN, one of our RNs answers the phone. And their goal is that they quickly try to figure out, does this person need our help? Do they meet criteria? And if they do, their whole goal is to get them landed within 1 to 2 days in an appointment, because we know that there really is a golden hour out there where people have a thought, like, I just overdosed and they brought me back in the field, and now I'm scared and I want help, or their friend overdosed and died. So they call and they want help. And so they try to get them in within 1 to 2 days. And then at that first appointment, we've found that the most important thing is to meet them in a curious and non-judgmental way, have them meet a peer support who can say that the behavioral health person and the family doc or nurse practitioner, that we're safe. They're like, hey, I have a lived experience. I've been where you are. This is a safe place. They're going to help you. And then we need to get them their medicine, that buprenorphine, and get their brain stabilized, see them back in a week. When they come back on that those follow-up visits, that's when we start really talking to them about behavioral health. And a lot of times they're leery about that. They're not interested. But because we keep building up rapport as the physician and the peer, they eventually say, okay, I get it. You're saying that I need to work on my triggers, or I need to have better coping mechanisms. And then they almost always, but not always, accept behavioral health and start doing that in our group. It's awesome. So next slide. And we get it that not one size fits all, but in a federally qualified health center, in an integrated model, they come in, and once they realize, wait, you're not just taking care and refilling my buprenorphine, you can help me with my high blood pressure, my pre-diabetes, you can get me my vaccines, I can get set up for Pap serum mammogram. They really do love it. We take care of them. Then fast forward a year, if they're doing really well and really stabilized, they love that they can start seeing us by telehealth. And every so often we do need to bring them in to see them in person. They can jump into behavioral health when they're having life stressors, and then jump back out of it when they get through that. Next slide. So the role of the different providers really quickly. My role is to screen our patients, and then the brief intervention is, hey, I want to be able to help you. Maybe I've been writing your medications for your chronic pain, and now we've just discovered that you have an opiate use disorder. And the brief intervention is, hey, I have this medicine, buprenorphine, I can help you, and I have a team that can help you. And the referral to treatment, because we've now trained all of the residents and the faculty and the APPs, is that you can be seen here. We can take care of your primary care, your behavioral health, and your substance use disorder. And we have a team. You're going to be in just one room, and we're going to swirl around you. Next slide. And just to bring it back home of why this is so important, if you have an opiate use disorder and it's treated with one of the medications, you're 82% less likely to die from an overdose than if you have an opiate use disorder and it's not treated by one of the meds. And if that doesn't, that should convince all of us. But for some folks, there is the economic argument. And I just want to say, like, it is expensive to arrest somebody, put them in jail, and get them in front of a judge. And we know that these medications can really save a lot of money to the system, maybe not just to the healthcare system, but to the whole system, including DSS and people's kids getting pulled into foster care and all that stuff. And by seeing them in an integrated model and having behavioral health right there, having the behavioral health to help work through their goals, particularly like, hey, I want to unify with my family, those kind of things. We believe that we're saving lives, but also saving the system an enormous amount of money. So next slide. And how is it really done? Just so you can kind of hear, by the time I walk in on a new patient, the peer has been there and it's established a rapport. The patient is really nervous and sometimes cagey about what it's going to be like. They're waiting to be judged. They're more at ease because of our integrated behavioral health and that peer being there. I come in and talk to them. That first visit is pretty short for me unless they have a lot of questions. I'm getting them their med, making sure that I get it to the pharmacy they want. And when you say, like, well, how do you choose their medicine? It literally goes like this. Hey, I'm glad you're here. I'm glad you're alive. You're going to get your buprenorphine. Have you ever used buprenorphine instead of you said you were using fentanyl when you overdosed? And 9 out of 10 of them say, yes, I've used buprenorphine. And I say, what dose works for you? As long as they say anything between 8 and 24 milligrams, I write that for a week, and then I see them back. And when they come back, that's when we then have the behavioral health interact with them more and try to get them into counseling. Next slide. So I'm going to pass it on.
I'm sorry to interrupt, but because this is 45 minutes and you have a chunk left to do and we want to have some Q&A, can you do like a high level of what you have left?
Totally. Yep. I will be mindful of time. Here's some of the common conditions that we try to help treat along with folks. Substance use disorder. We really try to focus on trauma and the effect of adverse childhood experiences on folks. Oftentimes that includes educating the patient on the chronic and varied effects. It's not just on mental health or substance use, but a host of conditions. As you see here, the average ACE score for our patients is, I would guess, far greater than for most other populations. For behavioral health, I think we play a really key role in providing trauma-informed care and really setting that tone for that curious and non-judgmental care that we expose and helping to educate staff as well. Trustworthy transparency, collaboration. We're really creating an environment where patients feel comfortable in being open and vulnerable and collaborative. I will skip past that. What does my role look like? So Dr. Fagan hit on the consulting role there, where on my consulting days, I'm joining him and our other prescribers as co-visits, which, if we're thinking of, if the title of this is increasing access to care, I think that plays a vital role in freeing up Dr. Fagan to then move on to the next patient and help with the things that really only he can help with. And I can kind of either, see him ahead of time or stay behind and work on, the housing issues, the depression, the anxiety, setting them up for therapy if that's what they want. Really key at the bottom there. I want everybody I hope this is a takeaway for everybody from this: requiring behavioral health services. And I'm saying this as a behavioral health clinician. Requiring behavioral health services is not an evidence-based practice. So we never withhold medical care for a substance use disorder because the person is not ready or willing to engage in therapy. We can still do a lot of good just by prescribing medications. Therapy doesn't work for everyone. Part of that is because you have to schedule it and show up in a way that is challenging for many folks. So we have found that peer support really helps to fill those gaps for the folks that can't attend therapy. So you see there how to become a peer support. The advantages of integrating peer support into your integrated behavioral health team. It's low barrier, it's flexible, and patients often relate better to a peer support than anyone else on our team. It gives patients a sense of hope that, as something to aspire to. I've had so many patients over the years. At once we started utilizing peer supports to say, like, I want to be them when I grow up, and in a lot of ways I do too. Our peer supports are wonderful. I also love the effect that it has on the team. I like the saying, nothing about us without us. And, having peers on the team really changes kind of, can change the tone and that non-judgmental place where I hope we're all coming from. And we see there at the bottom there really strong evidence for utilizing peer support specialists.
Probably should wrap it up, Zach.
Yeah.
Oh,
Questions?
okay. Wonderful presentation. Let's go back to the screen. I want to open it up for questions and comments. And while we're doing that, you can raise your hand and we'll recognize you and so on. There already was one question in the chat box. If someone prefers detox over medically assisted treatment, what do you do? Do you do referrals? And yes, the answer was we do referrals, and there was an answer put into the chat box addressing that. Are there other questions that people have that they would want to raise to our two speakers here? And while we're waiting for that, I actually had a question as you went through the presentation. I was interested in knowing a little bit more about who your clients are. Who are the clients who are in this program? How old are these clients? Are these clients people who are homeless? Are these clients people who are working? What's their relationship with their family? Can you characterize your clients in some way? Because I think that would be helpful to people.
Yeah, I think it's changed somewhat and kind of ebbs and flows partly depending on some of the projects that we're working on. So initially, I would say it grew mostly by word of mouth, and so the most common referral source I would hear from patients was other patients, which always feels good. But since then we've had other opportunities to focus on different populations. So probably the one I'm most proud of is our work with our local EMS and community paramedics who have given us a pathway into care for folks who've experienced an overdose. So they administer Narcan, they offer buprenorphine in the field. They will give them the medication for 5 days and then refer to us for follow-up. And thankfully we've been able to fill that role because we get people into treatment quickly. We really value that. And so we've seen our population shift in that way as well. Many of those folks are experiencing homelessness and have significant social determinant of health barriers. So we wrote into that grant a peer support special, actually 3 peer support specialists to really help with that. Again, being more flexible with their scheduling than I can be, and so they helped us. They helped us maintain a retention rate in that care for that population that is far higher than anything I could have ever hoped for.
Yeah, excellent. Josh Gettinger had a question. You had your hands up.
Yeah, I actually wanted to give you all a little bit of a feel for the setting in which Blake and Zach are working, which is one corner, as it were, of a very much larger clinic in which we do primary care in other settings. And I think that the impact of their work within the group that you saw is well beyond that. I, for example, in a panel of about 400 patients, have about I think 3 or 4 or 5 patients for whom I prescribe Suboxone, and I have them available to me as a resource. I'd kind of like to hear, Blake, more about your work in disseminating the idea of opioid use disorder treatment in primary care practices around the state of North Carolina.
Yeah, I know we're running out of time and there might be other questions, but thanks, Josh. So we have a program where the state of North Carolina has funded us to go to residencies in North Carolina, OB, emergency department, pediatrics, internal medicine, family medicine, and psychiatry, and stand them up if they are not prescribing buprenorphine. So we have a whole system where we go in, we identify a champion or champions, we train them, and then we consider it a closed or a residency that's working. If the champion says, we're now prescribing buprenorphine in our clinics and we're training the new residents every year, then we're like, we won. And we've been going across the state, and we still have a few more residencies to get to, but we've been very successful with that model. And we're hoping then that because more than 50% of residents, at least in the primary care settings, stay within 100 miles of where they graduate, that they'll populate North Carolina with folks that are really comfortable with buprenorphine, and we teach the integrated behavioral health model.
So North Carolina is actually an interesting place for integrated care, because for many years, at various levels in the state, there have been statewide activities to promote integrated care. So I think you're coming into an environment that's probably more accepting of integrated care in North Carolina than you might actually be in some other states. There were a couple other comments or questions in the chat box. One was about, how do you deal with the legal consequences of use of drugs and what may happen to these people legally here?
Well, I'd need to hear more about, specifically the kind of consequences you're thinking of, but we help folks navigate their legal situations all the time, and often being engaged in care with us is a great way to show to an attorney, a probation officer, a judge that I'm working to address my substance use disorder. And if you give me a chance here, I think I can do this, and we can save the system a lot of money by keeping me out of incarceration.
So does the reverse true? If a court orders somebody into treatment, do you accept those types of mandatory treatment patients?
I think we would. We don't, for whatever reason, we don't get those referrals very, very often. But yes, I mean, I guess as I say that, we do have several patients who are on probation, and they've consented for us to at least acknowledge to the probation officer that yes, they're in care with us. I try to share the minimum amount of information in those cases, and just say yes, they are making progress towards their treatment goals and they're engaged with us.
Excellent. There also was another, I believe, question about referrals from the criminal justice system, and I believe Dr. Fagan answered that question. So are there other questions from anybody else before I turn it back over to Cassie here? Okay, Cassie, seeing none, the floor is yours here.
Okay, well, thank you everyone for your questions, for your presentations, Blake and Zach. It's been you know, maybe 45 minutes wasn't enough, but we wanted to make sure we got people during their day and it didn't take away from their work. I want to thank you again for joining the Spotlight overall. Let us know through, well, actually, I want to say in the chat, we had how people heard about this was through our integrated behavioral health work group, but also the mental health section. Several people, APHA listserv and APHA lead, which might be the same, but so thank you for that. Let us know, respond to something you received if you have ideas for a future Spotlight. And if you'd like to join our section, or in this case, also the mental health section, because we have enough interest there, let us know. And there's written on the bottom of the screen where to send your suggestions. Sorry, Natalia, I forgot that you could send it there. Any other closing comments? We hope to have another Spotlight or two this year before the annual meeting. Here's some information on joining the section or the ATOD section. We have worked quite closely with the mental health section as well on this.
So I assume, Kathy, you would be interested in any input that anybody has here on potential topics for your next.
Oh yeah, absolutely.
Yeah, excellent. Excellent. So thanks again to everybody. It was a wonderful session. You know, it's very, very important work. As I said at the beginning, integrated care is the most important work we're doing right now. And I think in general, we need a lot more people like you all working on this out there, doing training, doing actual care to move the field ahead at a more rapid pace than has been true in the integrated care arena. So thank you all again very much.
Thank you.
Thanks for having us.